Bismillah. Neurofibroma. So, neurofibroma is a benign tumor, and sometimes it is dermal, sometimes it's deep seated. I'm gonna talk mostly, probably in general actually, but mostly about it being a dermal lesion. So, clinically, it's a localized, painless. If it is localized, it's gonna be a painless, violaceous papule or nodule subcutaneous mass less than 2 centimeters, and it has this buttonhole sign where this is your growth, and you push on it on your finger, and it's like you're pushing over a button that goes in and slowly goes out. Okay, if I understand it right. Of course, it's pushable. That's the idea, that it flattens and then goes back to its original shape. It can happen, this localized one, it can happen on the trunk, head, neck, and extremities, and really can happen anywhere in the body. Okay, so I've got images in here that should help. Just be warned that it's a little bit of a horrifying, terrifying thing to look at. However, it's not malignant, but it can have malignant transformation. So something like the localized painless one would look like this one, right? So on the left side we have the dermatofibroma, if you've watched that video, and this one is what looks like a nodule papule. Actually, it's more of a papule, and it's jumped up. It can be pedunculated, and if you push on it, it will flatten, and if you keep it, it will raise up again. As you can see, it's a little bit hyperpigmented or the same color as the skin, as opposed to the dermatofibroma, which looks different with hyperpigmentation, and it's just a bump of the skin. It's mostly flat. It's not like a papule or a nodule that is much larger and much more protruded. It actually can be like a nodule, as we saw there. Okay, and it can be anywhere in these areas and really anywhere in the body. I've seen pictures that it can be in the eye, around the eye, and in the mouth, in the intraoral cavity somewhere. It can be deep-seated, intramuscular. I think that it can be invading to the muscle. Anyway, just be careful, there is a good image in here. Okay, so this guy has an intraneural one, which is a very large one, and as you can see, this guy is a pretty good candidate for saying that he might have NF1, which is neurofibromatosis 1 mutation. We'll go over that later probably. See this? This is probably sitting right next to his spinal nerves and growing out of it, and it's gonna cause paresthesia and numbness and loss of function and everything, and that's basically gonna be either the diffuse or the plexiform. Plexiform is very likely going to be this one because it can affect the spinal nerve roots. Diffuse and localized are rare, difficult to become transformed. However, plexiform one is more of the one that's likely to transform into the malignant perineural sheath, yeah, so it's called malignant peripheral nerve sheath tumor. Peripheral nerve sheath tumor, because it occurs in the peripheral nervous system. So peripheral nerve, malignant peripheral nerve. Okay, peripheral nerve sheath tumor. Okay, yeah, that's it. Okay, plexiform, as we said, can occur in these areas. Diffuse It's gonna be indurated plaques, thickened skin, numbness if it's large enough to cause, you know, paresthesia and other symptoms that affect the nerve functions can usually occur in the head and neck. And yeah, we talked about the plexiform one. It's superficial, hyperpigmented, nodule or deep-seated lesion. Those two, the special types, are associated with NF1 mutation, with the plexiform having a very strong association with it. And it's very important to know those patients to make sure that we do genetic testing or whatever test they do in the laboratory, because there are so many tests I couldn't understand all of them. For our gross description, again, localized, which is the localized form without sporadic form, you can say, usually is localized. It's nodular, homogeneous. It can be tan or myxoid, translucent surface. It can look like this one or this one, but this is specifically what they said as a plexiform neurofibroma. And this is a malignant transformation one. Of course, it's really difficult to understand which one has the malignant transformation or not, just from gross examination. The diffuse cutaneous one may be flat or pedunculated, like this one. It's likely flat or pedunculated from the lesion itself on the skin, head and neck. And then intraneural one is going to be solitary fusiform, and fusiform means spindly shape. Mass, okay. So plexiform just means that it's a network of a growth. It's a plexus looking like a network, and they can call it a worm-like growth. It's really difficult to give that description in here, but if you're imaginative enough, you can think about these as worms growing into multiple lesions, even in here. All right. So microscopic is very important, and that's basically what we'd like to know. What's the conventional look of neurofibroma under microscopy? Let's see the images. Okay, so it's better to see an image. So what we've got, this is a conventional one, and the conventional ones, they are usually just uncircumscribed. As you can see, there is no fibrous capsule that denotes them. There is nothing that surrounds them. What's another thing? So they are dermal or subcutaneous. They usually have a low cellularity. As you can see, it looks like a normal stromal cellularity. There's a good amount of myxoid here. It looks like mucinous myxoid to collagenous stroma. Here it's more of a collagenous stroma. There is the shredded carrot appearance. Okay, shredded carrot appearance. So the pattern of it, you remember myxoid and shredded carrot collagenous stroma. So here are two pictures. You have the myxoid. Why does it look like myxoid? Mucus is a pale staining drops or fluid that looks pale because it doesn't stain with anything, on H and E, doesn't stain with any color, and because it's cleared during processing, so what remains is the look of the mucin itself, because it is a fixated tissue. This is carrot and myxoid. Okay, so that's one part. So we said non-capsulated, non-encapsulated, dermal or subcutaneous, low cellularity. It's an infiltrative spindle cell neoplasm, very loosely arranged. As we said, it is of a low cellularity, wavy spindle cells in a pale staining stroma. So very typical. This image is a very nice one, and this image is a very nice carrot appearance, carrot shredded appearance of what you might want to think. Again, myxoid, not much cellularity. It's a pale staining spindle cell area. Again, it looks the same. Here the arrow is variably myxoid stroma. Here the arrows are saying black arrows for melanin pigmented areas. Melanin pigment does not change any of the stuff. So what cells do we see? We see Schwann cells, perineural cells, fibroblasts, and mast cells. What do they look like? Wavy spindle cells in that pale staining stroma. Sometimes they surround adnexal structures, and they just surround them, they do not infiltrate them. Some types, intraneural subtype, nerve fibers can be easily identifiable. They can be easily identified. Anyway, so these are your core images if you want to remember it. Low cellularity, myxoid, carrot shredded appearance. If you see the cells, they are mostly spindle cells. Spindle cells with a wavy appearance like here. So they are neural cells. Right? Neural cells. Wavy appearance. Okay? Here, it's not that important because as a beginner level, but if you see this, you've got to think about multiple. So these are multiple nerve bundles, and they are very related to plexiform type. Okay, this is what a plexiform type would look like. Monomorphic cells replacing large nerve bundles, like a bag of worms appearance on low power. So if you see this, it looks like a bag of worms, as histopathologists like to call it. I don't see what worms they're talking about, but I guess it's just these things. It's a bag of worms. Maybe these are the worms that are inside like that, but it feels like these are just vessels on low power. There is another appearance that's important to remember other than plexiform, and of course it's of a very high stage until you got the concepts. For me, I think that these are the 4 images to remember, and this is the information to think about, really. Anything else would definitely be difficult. There is a typical neurofibromatous neoplasm of uncertain biological potential, or ANUB, whatever you want to call it. It's a pre-malignant tumor they do not really know if the potential is actually what's causing it, of uncertain biological potential. The changes are these two, CDKN2A and B, and it can transform into malignant peripheral nerve sheath tumor, MPNST. It's a very nice thing to remember once you get the concepts. So it looks like an increased cellularity, a very large word in here. Increased cellularity means poorer prognosis. Okay? It's typically of a hypocellular area. Nuclear atypia is not there usually in the conventional types. Okay? Mitoses are there. Mitoses are not there either. So if you see nuclear atypia, increased cellularity, mitoses, structure, architecture does not matter. So this is a plexiform neurofibroma, and it does have that part. This is a plexiform neurofibroma, and this is one that has this uncertain biological malignant potential. Uncertain biological potential. And that's all about it. Your other thing is the stains. So what would you do? You would do an S100 and SOX10. Milan A is very important because you want to differentiate this from melanocytic lesions. Of course, melanomas would look different. Collagen type 4 would have a very strong positivity. EMA and GLUT1, if you want to remember those, these are for the plexiform type, and they are really good for it. If you are worried about malignant transformation, you can do P53, which is strong in these ones, all right, over neurofibroma. So it's a differential diagnosis in your head. Which one do you want to do? And this is your pack. SOX10, S100, collagen because it's a collagenous lesion, EMA, GLUT1, Milan A. You can throw Milan A with these ones. EMA and GLUT A and P53, these ones are just for you to differentiate it from the pre-malignant or the worst types that have a worse prognosis. And of course, if you've got this one for positivity, you gotta think of your mutations, because this one has a very strong association with with NF1 mutation. Anyway, now hopefully this one is helpful. It was helpful to me, of course. These are your references, and it was from the Washington Manual of Surgical Pathology, and there was a lot of information on pathology outlines. I didn't include all of it because it's gonna be like a 50-minute video, and I wouldn't understand most of it, as I only understand probably 80% of all of this information. And you take care. Thank you. Bye bye.